All right. So
Yeah,
yeah,
looks
so
good.
it's good. So this is Yohei. So this is the case presentation of the patient that I saw. I think that was 2 years ago when I was a fellow, and it's an interesting case to share. So this is 36 years old man who had no relevant past medical history, but he had progressive lower extremity weakness for 2 years. And then what was interesting was that he kind of preferred to use his left leg rather than his right side because he knew that his right side was a little bit weaker than his left side. And there was no family history for the similar condition. And then before he came to Duke, he had the workup at the Alzheimer's hospital, and then he had high CK, more than 4,000. EMG study was showing the myopathic changes. Muscle biopsy was also done, and they said there was some rare inflammatory cells, but he had no response to steroid or methotrexate or Imuran. So that was basically why he came to Duke for the second opinion. On the physical exam was also interesting. So there was asymmetric lower extremity weakness, atrophy. So on the right side, again, was a little bit weaker than his left side. And then there was no weakness in his upper extremities. And then I think this is kind of a striking picture too. So we saw the asymmetric muscle bulk. It was obviously small on his right side. So we noted that the difference in between the two. And then, so this is sort of the differential diagnosis, but more for the sake of education. But when we see that myopathy with asymmetric distribution of weakness, we think about FSHD, IBM, obviously not the case for him, but the other types of the limb-girdle muscular dystrophy, like 1C, 2B, 2L, so that can be listed as a differential. So thinking about that, we did the workup, including the nerve connection sheet. So we saw abundant fibrillation potential, positive shock waves, and also many small stable multi-unit potential. So they all looked myopathic changes. And then we asked the facility to send a muscle biopsy to us, and then we reviewed by ourselves. And then on the H&E stain on the A, so we saw that kind of variable muscle fiber sizes. And then the B is that theophlavin T stain, and the C and D are the congruent. And then we saw the amyloid deposition in the muscle biopsy too. So now we got the high CK, asymmetric weakness, and then the muscle biopsy showing that amyloid deposition. So we are thinking about anoctaminopathy at that time. And then the molecular genetic testing came back, and that was positive for the homozygous pathogenic mutation of the NO5. So that sort of established the diagnosis of that anoctaminopathy. So it's kind of short presentation, but the take-home message is for the differential diagnosis for the asymmetric weakness with elevated as a differential diagnosis. And then it can show the amyloid deposition in the muscle biopsy too. So that's all for me. Thank you for your attention, and then thank you for your time.
Thank you, Yohei. Wonderful.
Thank you.
All right. Well, it's me again, and I'm not introducing the grand round speaker. I am the grand round speaker. I was rousted out of bed at 7:30 this morning by Brian to tell me that our scheduled grand round speaker, Sven Poli, has had a medical issue with his wife and won't be able to do it. So the show must go on. And I'm sure he was going to tell us something amazing, but we've already got Brian, so here we go. So I'm going to talk about dementia. I just gave grand rounds at Penn, and I just am resuscitating that for those interested in doing it. And we're going to start with some simple definitions. What is dementia? Dementia means that someone, as you all know, has cognitive impairment that are incapacitating or really affecting their ability to function. Mild cognitive impairment means they have real cognitive issues, but their function is still quite excellent. And subjective cognitive impairment is defined as someone who's worried about their memory enough to go see a doctor, usually with a family history, but whose cognitive testing is normal. And then as we all talked about, delirium just means an abrupt change in cognition, usually with a patient with an underlying cognitive disorder. Now, the causes of dementia and MCI are the same thing with one exception. About 20% of patients with mild cognitive impairment don't progress with time. Last Friday in my follow-up clinic, I think I had 3 of them. And you tend to accumulate them in your clinic because they don't progress, they don't die, they don't wind up in nursing homes. So you tend to follow them. And when you see them patients initially, you're always hoping that that's the way they will turn out, but it's uncommon and it does happen. If you look at their brains when they die, there is nothing in there. I mean, there's brain tissue, but no disease. So why they have this cognitive funk is unclear. But the causes of neurodegeneration, and there's one person out there who's not muted, so please take a look to see if you're muted, is Alzheimer's disease, the most common. Lewy body dementia is a variant of Alzheimer's disease associated with Parkinson's for the most part, although Andy Liu would tell us that there are some people with a pure Lewy body variant. Parkinson's disease with dementia. Frontotemporal lobar degeneration, which a lot of people aren't aware of, but we see quite a bit of. Chronic traumatic encephalopathy. And there actually is a vascular dementia, but it's not strokes. It's either CADASIL or CARASIL, which are very rare vascular angiopathies. And then in older folks, there's multifactorial causes, with Alzheimer's and stroke probably being the most common combination. And when we tell a patient that we think they have one of these diseases, what we're doing is we're predicting the pathology. In other words, if I say, I think you have Alzheimer's, I'm predicting your brain will have plaques and tangles. Where if I say, I think this is a frontotemporal lobar degeneration, I'm predicting they'll either have a sea of tau inclusions without amyloid, or in the bottom left, they'll have these aggregates of TDP-43 aggregated on top of a nucleus, which you don't see in normal brains. And if we think they have a Parkinsonian dementia, we're predicting Lewy bodies. And if we say they have chronic traumatic encephalopathy, we're predicting that they will have this really unique pattern of tau and TDP-43 accumulation at the basis of these sulci, which you just don't see in Alzheimer's disease, which is why CTE is accepted as a new degenerative state. And these inclusions contain both TDP and tau, which is not what you see in the frontotemporal lobar degenerations. Now, the etiology of dementia changes with age. If you look in the 50s or 60s, and I'm leaving out Huntington's disease here, if you look at the 50s and 60s, you see early onset, what they call early onset Alzheimer's disease, but only a small fraction of that early onset is autosomal dominant. Autosomal dominant is important biologically, but not much of a public health issue. It's just a small fraction of all degenerative brain diseases, and usually between age 50 and 60. But down here, you see degenerative diseases that are due to the presence of the APOE4 genotype, along with some frontotemporal lobar degenerations, and then a little later on, some Lewy body dementia. Then as people hit their 70s and 80s, APOE3 is the major cause of neurodegeneration, along with tipping points, stroke, surgery, and delirium. And then into the 90s, E2s and E3s turn comes, and then the incidence of dementia may start declining in the 90s or may not. And then you get some real weirdos out here. Age-related TDP-43, primary age-related tauopathy. And so, you know, what you might say, well, why you got this big old E3 out here? I thought that was neutral. Well, E3 is good compared to E4, but it's not good compared to E2. If everyone in the United States was APOE2, E2, there would be no Alzheimer's disease, absolutely none. So the reason 70 and 80-year-olds get it is because they have an E3 rather than an E2. Okay, that just dawned on me about 2 weeks ago in clinic. What about vascular dementia? And I think there's a better phrase that I'm going to try to get you used to, which is the vascular contribution to dementia. This is an MRI of someone with codicil. And codicil is a vasculopathy, progressive, that leads to dementia. And it has severe white matter changes, evidence of stroke. And the characteristic is that the white matter change extend into the anterior temporal horns. But presumably at some point, they're not there, they're just up here, and they can kind of look like this. But codicil and its recessive variant carousel are incredibly rare. And white matter changes are incredibly common. The radiologist always call these white matter changes microischemia, but they're completely wrong. If your brain is sick, if your gray matter is sick, your white matter is sick. If your brain is unhappy, your white matter is unhappy. Study after study has shown that white matter changes are common in Alzheimer's disease and super common in the frontotemporal lobar degenerations. I remember President H.W. Bush was said to have vascular Parkinson's late in his life, almost certainly because he had severe white matter changes. But he almost certainly had a frontotemporal lobar degeneration. I mean, I didn't take care of him, but vascular Parkinson's, that's nothing. That's not a thing. I'm sure it was a frontotemporal lobar degeneration with severe white matter changes, which is common, and that's why it was called that. And there's some real evidence that vascular disease impacts on dementia, not necessarily Alzheimer's disease. There's a lot of good evidence the incidence of dementia has been declining over the last 20 years, not the prevalence. Prevalence is due to the fact that the population is aging, but age-specific incidence is on the way down. And that's mostly due to the treatment of cardiovascular risk factors and secondary to the increasing education level of the population, both of which seem to be protective for dementia. So how does this work? And it works because these secondary pathologies like stroke are tipping points. If you look at the brains of 70 and 80-year-olds when they die, a third of them have no pathology and they're cognitively normal. And those people can have strokes, and all they have is the deficit from a stroke. They don't have a progressive neurodegeneration. A third of people at that age when they die have a head full of Alzheimer's disease and they're demented. The other third have a lot of Alzheimer's pathology, but they're still cognitively intact. And the difference between those two groups, the demented and the intact, even though they have the same amount of AD pathology, is the absence of a secondary pathology like stroke. And this is just an example from the Baltimore longitudinal study of aging, but it's also been shown by David Bennett and his group at Rush, which is this group with low AD pathology scores, 2 to 3, that they really don't have a high incidence of dementia. Even with strokes, they're not that demented. It doesn't affect them that much. People with very high AD pathology scores are demented, whether they have strokes, which is the red dot, or they don't have strokes, which is the green dot. But the people in between with moderate scores, which is only 1 point, but it's where the vast majority of people live when they die. Those without strokes, the red dot, have a pretty low incidence of dementia, whereas those with vascular disease have a very high incidence of dementia. So it's the combination of the two disorders that leads to dementia in these groups. And we call these tipping points. And these tipping points not only include strokes, but they also include surgery, heart attacks, infections, and the like, where somebody was okay until X happened. And so there's no question that preventing stroke is an important way to reduce dementia. But its impact on the underlying AD pathology is pretty negligible. Now, that was turned a bit on its head by Rebecca Gottesman, who did grand rounds here on this a couple of years ago. And I think it's a really important study, and I won't go too much into the details, but what Rebecca and her group found out was that midlife what she called vascular risk factors, but what I beg her to call metabolic risk factors, like smoking, cholesterol, high BMI, were important risk factors for amyloid accumulation in late life. This is the first example of a study that found a link between a risk factor and amyloid accumulation. There are tons of studies that show these risk factors like high blood pressure are linked to dementia, but not to the underlying amyloid pathology of Alzheimer's disease. And this is a very, very important study, and I know Rebecca is following up on it. Now, as I said earlier, what does it mean to say someone has Alzheimer's disease? And in clinic, as we all know, it's complicated because families and patients believe Alzheimer's and dementia are the same thing. And they never, when you first explain it to them, they're almost certainly not listening. But over time, it's important, and some people do get it. What we're saying when we say someone has Alzheimer's is we're predicting their underlying pathology. We're predicting if we could look at their brain, they'd have plaques and tangles. Yeah, that we would see this kind of thing. Just as we said, if we think you have frontotemporal lobar degeneration, we're predicting another set of pathologies. Same with CTE. Same with the Parkinsonian diseases. But it turns out we're terrible. We're almost always, we're just guessing. If we're telling a 60-year-old what we think they have, we're got a 40% chance of being wrong. If we tell an 80-year-old, we only have a 20% chance because so much of the disease in 80-year-olds are Alzheimer's disease. So basically we're guessing. As I'm going to mention later, the biomarkers have had a big impact, or are having a big impact on how we, the certainty with which we apply to diagnoses. And until about 6 months, we were still doing things the really old-fashioned way by just talking to families and then doing some cognitive testing. And just as an aside, we're in the process right now, thanks to Carolina Quiroga, of getting our whole thing put on iPads. It's been a 6-year process, so we can dump a lot of the paperwork. We'll let you know how it goes. MRIs aren't done to say someone's got a memory loss. They're just done to say you don't have a brain tumor. The history as such is just a couple of questionnaires. The 88, which says, is your father repeating the same question over and over? The functional activities questionnaire distinguishes MCI from dementia by asking what they're having trouble with. And the neuropsychiatric inventory just says what behavioral manifestations they are. And the families usually fill out these forms while we're doing the cognitive testing, because as most of you know, when the family member starts describing the symptoms they see, the patient gets all angry at them because they think there's nothing wrong. So while they're out filling out these questionnaires, we do a cognitive testing. Mostly my colleagues do the MoCA, I do the DUCE. For people who do well on the MoCA, we do a very simple memory test called the HVLT and TRAILS-B, and that's pretty much all you need. We hardly ever get cognitive testing formal. And then we do a couple of depression scales and an anxiety scale. And you come away with a couple of rules. The first is the caregivers are never wrong. Even if the cognitive testing is normal, it's probably just early. Rule number 2, you can't diagnose just by testing the patient. You need the input from an informant. This goes to the issue of how do you decide if there are norms in different groups, how education impacts cognition, et cetera, et cetera. And rule number 3 is you have to see the patient back in 1 year, no matter what. What about MRI atrophy? I always like to show this slide because I point out it's the one on the left, the normal one that's demented. The one on the right is, as they say, sharp as a tack. Atrophy is a very poor predictor of cognition. We've already talked about white matter changes. Asymmetry does matter in a young person. Asymmetry, like in this parietal lobe or this temporal lobe, or these frontal lobes, are often a sign of frontotemporal lobar degeneration, not so much in older folks. And then just to throw in a normal pressure hydrocephalus, which we had a great grand rounds on from Abe. You got big ventricles, widening of the sylvian fissures, crowding at the top. and a patient with relatively intact cognition and a significantly Parkinsonian gait, a certain percent of them will respond to a large volume tap and long-term shunting. But almost all these patients also have underlying degenerative diseases, so you never tell the family that you're going to make their cognition better. You're just trying to make their gait better. And it's a really tricky diagnosis that should be handled by patients who just do this an awful lot, by doctors who do. Now, this gets to what I was talking about before. Last year, there were two very large studies, the IDEA study and the ABIDE study, that looked at experienced clinicians' diagnosis of Alzheimer's disease, and then did a amyloid biomarker scan to see if the doctor was right about it being Alzheimer's or non-Alzheimer's. And they found that 30% of the subjects were misdiagnosed by this criteria. These were subjects who tended to be in their 60s and early 70s, in whom the incidence of non-AD dementia was still high. So when someone says their mother have Alzheimer's, you say, well, did they have an autopsy? Because unless they had an autopsy, nobody really knows. And still to this point, it doesn't really matter which form of degenerative disease you have, but we'll talk about that in a second. So talk about it in this second. So they don't progress any differently. All forms have slow and fast progressors. The symptoms overlap in groups of 1,000. People with frontotemporal lobar degeneration have more, let's say, disinhibition, more Parkinsonian symptoms, but plenty of Alzheimer's patients have those too. Lewy body dementia probably is a unique syndrome that can be sorted out, but and there's no difference in treatments. There is a difference in genetics. Alzheimer's disease is a highly genetic disorder due to APOE, whereas frontotemporal lobar degeneration in 70+% is sporadic. So there's no family history and there's no risk to the children of patients with frontotemporal lobar degeneration. That took me a long time to wrap my head around. How could you have a neurodegenerative disorder without a bad gene? Until you think that ALS is a frontotemporal lobar degeneration, and ALS is sporadic in most cases as well. So probably in the area of genetics is the one major difference between these diseases, but that's probably about it. Are there reversible dementias? Forget about it. If you read a textbook, they'll say something crazy like 5 or 10%, whereas I would say 5 times in a career is all you're going to ever get. And those are almost always autoimmune encephalitis. Because they're sudden onset, they fluctuate, have seizures. I take the rule that if you don't have seizures, you don't have an autoimmune encephalitis. The actual number is probably 80%, but now in the days where we're doing lumbar punctures right and left for AD biomarkers, you can easily throw in an autoimmune panel on somebody who you're a little concerned about. 20%, as I mentioned, of people with mild cognitive impairment are stable and have no brain pathology. And there are things to consider: obstructive sleep apnea, medications, depression. Those do make patients with degenerative disease worse or feel better, but they don't cause it. We tend to see a lot of patients with fibromyalgia and chronic fatigue syndrome, and presumably soon long COVID, because they often complain of cognitive problems. But in these patients, the testing's pretty normal. It's just that they have a subjective sense of cognitive issues. But now we're in the land of biomarkers, thanks to Andy Liu, who's really been pushing these. So I tend to use these in people who are young or people in whom whether they have a cognitive syndrome isn't quite clear. A lumbar puncture looking for CSF A beta 1 to 42, which goes down in Alzheimer's disease, and CSF tau and p-tau, which go up in Alzheimer's disease. And this is a test sent to the Mayo Labs, and Andy does the lumbar puncture. Soon we'll have a CSF neurofilament light, which goes up in frontotemporal lobar degenerations, a little bit in Alzheimer's disease. The problem right now is if their spinal fluid comes back negative for Alzheimer's biomarkers, they could still have a frontotemporal lobar degeneration, but soon that gap in the testing will be closed. Andy's been doing a lot of skin biopsies for synuclein, looking for Lewy body variants, because in young people, some of them can occur without any comorbid Alzheimer's pathology. And now there's a plasma neurofilament light, which we send out to Mayo Labs, which is supposed to be elevated in frontotemporal lobar degeneration, and it's available, and we're getting it. Soon there'll be serum p-tau levels, which go up in Alzheimer's disease. And still one of the best biomarkers, APOE, is not paid for by Medicare, but you can get it on patients if they've had colonic polyps for no good reason, and 23andMe will test it as part of their medical panel for $100. So let me take a sip of coffee. So here's the data on plasma p-tau 181 and 217. The red are patients with known amyloid in their head by PET scan, and the black are patients without amyloid. And it's pretty impressive. This test seems to be able to detect the presence of amyloid in someone's head, not necessarily dementia, because some of these patients are cognitively intact, but they have amyloid in their head. So this test doesn't tell you they've got dementia necessarily, but it does tell you if they have cognitive symptoms, it's probably Alzheimer's disease. It also goes up in some other conditions which are worth remembering: stroke, MI, chronic kidney disease. And then the neurofilament light testing. This is a plasma neurofilament light, and I just put this red box. This is the box scores from patients, serum patients with frontotemporal lobar degeneration, and over here Alzheimer's disease. So it's a little bit up in AD, but up significantly in patients with Alzheimer's disease. So pretty soon we're going to be able to make these diagnoses just based on serum testing, but it won't make a damn bit of difference for the patient. Now, it's important to remember these are more than just memory disorders. And all of these can precede the cognitive symptoms: depression, anxiety, which late in the disease becomes shadowing and is a real problem, disinhibition, loss of empathy, which falls on the caregiver. They can't see the caregiver suffering, delusions, hallucinations, apathy, which is important to explain to the caregivers because this is not depression and won't respond to depressive treatments, aggression or agitation, anosognosia, which is, as you know, is just a lack of insight, which just makes the caregivers insane because the patient thinks there's nothing wrong and the family thinks they're just in denial, but it means they don't know they have it and they refuse help. And then gait disturbances. Symptom management is a disaster in this field. As part of the grand rounds, I reviewed all the medications on the Cochrane database. And what Cochrane says about Namenda and donepezil is they say with Namenda, there is no benefit in people with mild. They define mild as 20 or above. There's a small benefit in people with more severe diseases, irrespective of whether they're also taking a cholinesterase inhibitor. So a tiny little benefit. With donepezil, they found a tiny little benefit in mild, moderate, or severe dementia. And the interesting point is they said there was no data 23 milligrams, which is available, is better than 10. And they also said that 5 was just about as effective as 10, but as we all know, has much less side effects. So for my own way of doing, I might start using more, I mean, because these benefits are teeny, like 1 point on a mini mental, teeny weeny, and I might start using a little more 5 along with Namenda. The data suggests that they don't work in non-AD dementias, but they really don't work in AD dementias too. But I already told you, you can't tell them apart. So we use them on pretty much everybody. And the data that any of them work in patients with mild cognitive impairment is non-existent. Depression, first, separate depression from apathy. That takes a while to think about. Depression is a affective symptom. Apathy is just watching TV all day. In a young person, apathy is a sign of depression, but not in an older person with a degenerative disease. The Cochrane database says the evidence that SSRIs treat depressive symptoms is really weak. There have been 3 trials, none of them have shown any benefit. There's a 40% placebo response in these trials. We use sertraline like candy in clinic, although there's 0 evidence it does anything. For agitation and psychosis, Cochrane actually says, well, sertraline and citalopram are associated with mild reduction. So you could use them for this, which we do. Like everyone, Cochrane takes a shot at typical and atypical antipsychotics, both because it increases the rate of death and side effects. But I will tell you, in clinic, we use these quite frequently too, because when a patient's having a severe behavioral manifestation, there's nothing else available. And the point they make is that you need to reassess their necessity every 6 months or so. And I agree with that because these psychotic symptoms can fluctuate. They do recommend melatonin for behavioral symptoms. They say there's no data that trazodone or valproate does anything. Apathy, the couch potato syndrome, there are some studies showing that stimulants demonstrate benefit in a small group of patients, but the evidence is still low quality. I tend to use them. And then non-pharmacologic approaches involves education of the caregivers, respite care for the caregivers, like getting someone into the house to help them. Senior centers or daycares are just amazing when it works, but a lot of patients won't go because of the anxiety or apathy. There's a good behavioral intervention list from Paula Spencer Scott that I tend to start handing out, and it's free online. It's kind of a training manual for the caregiver and has the usual stuff. Don't try to reason, redirect, review possible causes. And then sensory stimulation, light, smell, music. And over the weekend, I heard about weighted blankets, which, let's hope they do something. So intervention trials, and this is where hopefully the biomarkers are headed. If they're going to be trials targeted specifically to Alzheimer's or frontotemporal lobar degeneration, you need to be sure. And there the biomarkers will help us do that as long as there's something of value at the other end. So why are the drug companies continuing to rip away at amyloid and tau? It's because they're there on the brain specimens. They're staring you right in the face. And because autosomal dominant Alzheimer's disease is related to mutations in the genes that process the amyloid precursor protein and generate A beta. This model, this autosomal dominant model, has been really powerful in the field. There's such rare cases, but they all involve processing the amyloid precursor protein into A beta, and all lead to very early accumulations of amyloid and then tau. And the standard model is you've got normal neurons, all the young folks out there at age 30. When you get to be an age I used to be, you're starting to accumulate amyloid, and then you're at an age I'm about to become. The amyloid has now caused neurofibrillary tangles, and then if I ever make it to 80, you start developing cognitive symptoms. And there is some evidence in mouse and human studies that this is a real model. The question is whether it's causative or just temporally related is still not 100% clear. And as I mentioned, amyloid, because of the autosomal dominant forms, completely ignoring the significance of APOE. And with tau, if you look at the brains of patients who die of Alzheimer's disease, amyloid occurs everywhere at pretty much the same time. There's no evidence that it really spreads. Whereas tau really spreads. It starts in the medial temporal lobes, starts spreading around the temporal lobe, and then moves up into the parietal cortex and pretty much is everywhere. It's almost like a prion disease. And the same data from mice where you can inject it into one side of the brain and see it on the other side of the brain in several months, which gives rise to the thought of a protein misfolding disorder similar to the prion diseases. And that's why tau has become now such a popular target as well. So to look a little bit at the trials, and we've heard about this before, this is aducanumab's gigantic disaster. So aducanumab is an antibody against the amyloid peptide. You infuse it into someone's veins, and through some miracle, it sucks the amyloid out of their brains. And there's no doubt it did this. And this is why the FDA approved it, because if you get it within 12 months, the amyloid's gone and it doesn't return. The question is, did that result in a cognitive improvement? And I think we've been through this before, but Biogen ran 2 studies simultaneously, 1,500 people. One showed no benefit. The other showed a very mild reduction in decline. The primary endpoint was called the CDR sum of the boxes, which means the CDR is a score of what the patient is having trouble with. And it's in 5 different categories, and you add all those boxes up. And the placebo in this one arm declined 1.17 points a year, whereas the control dropped almost 1 point a year. So just a trivial little difference, but that was enough to get Biogen to push for it. The FDA approved it not because of the cognitive data, because they said it really didn't have any real effect, but because of this biomarker data. So the FDA granted accelerated approval on the basis of biomarkers. The FDA advisors, all of whom voted against it, 3 of the 10 resigned. And then one of the reasons it was approved, because the Alzheimer's Association, for some crazy reason, really backed this and put a lot of pressure on the FDA to do this. It turned into a gigantic flop. Biogen stock went from 420 to currently it's in the 190s. The CEO and the chief medical officer and chief scientific officer at Biogen all had their heads chopped off, and Biogen terminated the study and terminated the distribution of aducanumab. I think in the end, only 100 Americans ever received it, and there are many side effects associated with it. But that's not the end. So there have been 2 trials of asymptomatic patients. In the aducanumab studies, patients had mild cognitive impairment, MCI. There have been 2 studies now of people with autosomal dominant Alzheimer's disease treated with these same antibodies before they had any cognitive symptoms. This is out of WashU, the DIAN study, which are autosomal dominant AD patients treated with either of these 2 amyloid clearing antibodies, using the primary outcome, the same one as Biogen, the CDR sum of the boxes. And this is the progression rate in the placebo, which is the dashed line, and the 2 treatments. Absolutely no difference. It was a smallish study, but no difference. Last week, the New York Times, it's not been published, reported the long-awaited study going on for over a decade of crenuzumab. We're going to be like the MS folks soon, knocking off all these antibody names. It was a study of a very large family in Colombia, South America, that had autosomal dominant Alzheimer's disease who were treated before they had symptoms. And the study, the newspaper version of the study showed that after more than 10 years of study, there was no benefit of this treatment. Unfortunately, the drug chosen 12 years ago has only a modest effect on brain amyloid. So it's a study that showed no benefit, but maybe the drug was the wrong one. There's still a large asymptomatic study ongoing in homozygote E4s. And that one should report out relatively soon. There's another study going on right now of another amyloid antibody. That's doing that. Called Dontatumab, which is a Lilly drug, which is on the right here, does get rid of the amyloid in people's brains. They just published their early study of 145 subjects with mild cognitive impairment. They're doing a phase 3 study, both in people with mild symptoms and in people who are cognitively normal but at risk. Dontatumab is an antibody to an N-terminal post-translational modification of the A-beta peptide. that's highly effective in reducing amyloid. And their phase 2 study, which was published in the New England Journal, their outcome was a made-up outcome of 2 different standard outcome measures in which they showed a significant difference. It's important to remember that aducanumab also showed a difference in its phase 2 study. But when they went and looked at the standard, which is the CDR sum of the boxes, which all the other antibodies have been assessed on, this is not statistically different at any level. And as you can see here, the mini mental, you still have to do a mini mental, really doesn't show any difference. It's just this, homemade up outcome score. So I'm sure it won't work, but we'll see. In addition, there have been a ton of tau studies now. These are anti-tau antibodies to clear off tau. A Lilly drug failed, a Roche drug failed, an AbbVie drug failed, and a Biogen drug failed. There's still a J&J study ongoing of an anti-tau antibody. Get rid of this. And there is an Ionis Biogen tau antisense antibody still going on. The thing with the tau antibodies is none of them showed a PET effect. So with this a tau PET scan, there was no evidence the antibody cleared out the tau, but there was evidence from CSF biomarker studies that they did have a positive impact on tau, and none of them affected cognition. So the question is amyloid or tau just really good biomarkers, or are these really the cause of Alzheimer's disease? And I don't want to be a total negative, because I always like to include this slide to convince people I'm not just a downer. There have been 2 studies now of treating amyloid in the heart, which has a dramatic effect on congestive heart failure and cardiac admissions. These are patients with transthyretin mutations that accumulate in the heart, and there are now small molecules which bind to that transthyretin, fold it back into a normal shape, which allows it to be cleared out. And they've both been very, very successful. But the difference between cardiac amyloid and brain amyloid is the heart is not the source of the amyloid in cardiac amyloid. It comes from the liver and for some reason accumulates in the heart. Whereas in the brain is the source of the amyloid and the tau. So there's reason to think that in the brain, the amyloid and the tau accumulate there because the brain is sick. Whereas in cardiac amyloid, the accumulation is a secondary phenomenon, not a primary phenomenon. So the underlying heart is probably healthy. And if you get rid of the amyloid, your symptoms are reduced dramatically. And there's a lot of reason to think that protein folding is tightly related to cellular energetics. And if neurons, glia, endothelial cells have issues with their metabolism, proteins are going to misfold because it takes a lot of energy to keep a protein folded properly and to digest it when it misfolds. And the best evidence of that is APOE. APOE, discovered, as you all know, its risk association by Alan Roses almost 30 years ago. APOE is a lipoprotein, meaning it binds to the surface of lipid particles, E2, E3, and E4, which then steers these lipid particles to cells by binding to these receptors called LRPs. Okay. And between having APOE2, APOE3, or APOE4, there's probably 100-fold increased risk for developing Alzheimer's disease. This was a study out of Eric Ryman and the Banner Group, which had such a large population. APOE22 in the population is incredibly uncommon, but they were able to put together a cohort of 2 2s, 2 3s, 3 3s, 2 4s, 3 4s, and 4 4s. And between 2 2 and 4 4, they found 100-fold risk, increasing risk of Alzheimer's disease, and made the important point that 3 3 is not neutral. 3 3 is an amyloid Alzheimer's causing genotype compared to 2 2, not compared to 4 4. But that's why later in life, it's the E3s who start developing Alzheimer's disease, and even eventually the 2 3s. And there was this incredibly important, the whole study in Colombia, South America was probably worth it for this one patient. This was published by Eric Ryman 2 years ago. This was a single patient who had the autosomal dominant mutation that predicted the development of dementia by age 55 with 100% accuracy, but she didn't get demented, lived into her 70s. And when she died, she was found to have just a brain chock-a-block full of amyloid, but almost no tau. And when they checked her APOE status, she had this very rare Christchurch homozygote mutation. And this APOE3 isoform was able to prevent dementia in the face of an autosomal dominant mutation, which just shows you what a powerful effect APOE, that and the 100-fold increased risk, shows you what a powerful effect APOE has on cognitive symptoms. And in the population is the cause, that and diseases that tip you over, like vascular disease, cardiac surgery, et cetera, et cetera. So now we're in the phase of gene therapy too. And Kim and Andy are investigating whether Duke can be part of this study. This is a study of an adenovirus injected into the CSF that is just going to be done in patients who are homozygous for E4, and using CRISPR-Cas9 technology changes the E4s into E2s. The difference between an E2 and an E4 are 2 base pairs. So this is a trivial little snip. And they've already done a 15-person phase 1 study to show that the technique works and is safe. And now they're gearing up for a much larger phase 2 study. And the question would be, is this happening too late? At what stage might it be done? I can tell you for sure, if you could convert every newborn to 2-2 at birth with a magical wand, there'd be no Alzheimer's disease. So the question is doing this when someone already has symptoms going to cause any benefit? And you know, it's a very exciting thing. It's the kind of thing that you'd be thrilled to send patients to, because it's not something that's already failed 4, 5, 6 times. So a little bit of excitement and hope in the field. Preventing dementia. Let me just get out of this now. Stop share. You know, if we see children of patients with dementia and they have an APOE4, there's pretty good evidence that exercise, being meticulous about your general health, and eating a good diet. Diet's become a big thing in the field in the last year, just kind of a modification of the Mediterranean diet. There's pretty good evidence that diet can have an effect. But the evidence that someone's going to change their behavior for 30 years to prevent a disease like this is 0. Some studies have shown that finding out you have an E4 has a modest to marginal effect on your behavior for 1 year. But I suspect that wanes pretty quickly. And the idea of behavioral manifestations to prevent diseases is the next frontier of medicine. People would be happy to take a pill or a shot that prevents it, but lifestyle changes are quite another matter. So the mainstay of therapy we have in clinic is exercise, which is very difficult when they have apathy, which they almost all have. Eat a good diet. That's hard, especially late in life. Meticulous care of their general health. That's something you can push on, because as we said, having a stroke on top of a degenerative disease is a terrible thing. And caregiver support. At our talk on Saturday, the speaker said, you know, if you live to 80, you have a 25% chance of developing a degenerative disease, and that's terrible. But he also pointed out that you also have another 25% chance of being a caregiver, which can be a decade-long role and is every bit as is painful and debilitating, which means your overall risk of being affected by this disease is almost 1 in 2 if you live to that age. So that's where we stand, and I'm happy to take questions. Marvin, you haven't mentioned the additional effect of alcohol because, Marvin, it's very controversial. There was a study published this year that a single drink a day over a lifetime causes brain atrophy, but whether it causes a degenerative disease. So first, alcohol doesn't cause a degenerative disease. The question you're asking is, does alcohol accelerate the symptoms caused by Alzheimer's pathology? And the data on that is not good. There have been studies that saying even up to 5 drinks a day doesn't bring it out. But as I said, there was a recent study saying even 1 drink a day was associated with brain atrophy in a large study, but brain atrophy is a poor surrogate for cognition. Oh, Marvin again. If the family says, I'm because of a study, sure, I got no argument with that. I mean, you're trying to help in any way you can. We're all doing that. And if families think something helps, sure. I got no issue with that. As I said, we use SSRIs, sertraline, and neuroleptics like candy, and the data that they work or harm is just not there. We're just trying to help, and any way you can do it. They don't allow us to hand out placebos. So in the absence of placebos, we have donepezil, Namenda, sertraline, and risperidone. Is there any benefit conferred by A4 versus E2? What do you mean, Andy? Andrew, what do you mean by that?
I just mean, sometimes we look at mutations that occurred because they conferred a benefit, and then
I see.
Downstream effect, there's this effect on Alzheimer's.
I got it. So humans are the only species with variants in APOE. Every other species has just 1 APOE form. So there is thought that that early on, APOE4 was somehow protective against childhood illnesses. They've talked about diarrheal diseases, but it's not clear. But that's the thinking in the field is just what you said, that there was some benefit to it early on, and that's why it's persisted. Yeah, because nature didn't care about what our cognition was like when we were 10,000 years ago. Thank you, Wayne. Any other questions? There must be questions. No? All right. Well, sorry for your disappointment this morning, but the show must go on, and I had a ready-made talk, and happy to do it at any point. Alzheimer's and dementia are huge problems. It's interesting. I think of it as a primary care disorder, not because it's not complex, just because there's just so much of it, that to think neurologists are going to be the secret of care is, I think, misguided. The primary care doctors have to be brought in, but most of them don't want to be. They've already got so much to do, and I can certainly understand that part too. But it's more common than diabetes probably is, and not as common as hypertension. But in my mind, it's a primary care disorder. All right, everyone, be safe, enjoy, and have a great weekend. Yeah, we got the 4th of July weekend come up. So, have a good, safe weekend, and see you next week.